Good day and welcome to the very first annual World Chronic Cough Day. I am Tanya Winders, the President and CEO of GAP, the Global Allergy and Airways Patient Platform, your host for today's webinar. And it's my pleasure to welcome Dr. Peter Dicpinigaitis. Dr. Dicpinigaitis is a professor of medicine at the Albert Einstein College of Medicine in New York. He is board certified in internal medicine, pulmonary disease, and critical care medicine. He's faculty at the Division of Critical Care Medicine at Montefiore Medical Center and is the founder of the Montefiore Cough Center, one of the very few specialty centers in the world committed to the evaluation and management of patients with chronic cough. Dr. D, as he is affectionately called by his patients, has received his undergraduate education by NYU, graduating summa cum laude with a degree in biochemistry, and then obtaining his medical degree from the NYU School of Medicine, and remained at NYU Bellevue for internal medicine residency training. He completed his fellowship in pulmonary and critical care at Mount Sinai Medical Center in New York, after which he came to the Einstein Montefiore staff. In addition to experience in all aspects of clinical medicine within the spectrum of pulmonary and critical care, a major focus of Dr. D's research for more than 2 decades has been in the area of cough. He has authored numerous peer-reviewed journal articles and book chapters on cough and is considered an authority on cough challenge studies and clinical research. He also has served as the co-author on cough management guidelines published by the American College of Chest Physicians and the European Respiratory Society. He is the founder and chairman of the biannual American Cough Conference, and Dr. D also serves as the editor-in-chief of the journal Lung. Welcome, Dr. Peter D. Thank you for being here today, Dr. D.
Thank you, Tanya, for that very nice introduction, and it's really a pleasure for me to be here on this very important day with you, so thanks for inviting me.
Yeah, the first annual Chronic Cough Day, October 15th, 2024. We're so excited about this. It's a global effort to recognize cough as more than just a symptom, but actually a disease, a condition that impacts so many. So let's start out by just talking about what is recurrent chronic cough?
So you actually made a very important statement already about RCC. So as with everything, definitions are important. So to understand the definition of refractory chronic cough, which we'll say RCC from here on in, we really need to take a step back and make sure we understand what the definition is of chronic cough. Now, we as doctors, when we see a patient with a cough, we first ask, how long have you had the cough? And the reason that's important is that depending on how long you've had the cough, that informs us as what the likely reasons for the cough will be. Right? So an acute cough is a cough that's been with someone for less than 3 weeks. And almost all acute cough is due to a viral infection of the upper airway or common cold. A subacute cough is a cough that's been with someone for 3 to 8 weeks. And usually that's just a prolonged acute cough after a virus or a bad cold. But once a cough is 8 weeks old or longer, then by definition it's chronic cough. And the reason that's important is once somebody's had a cough for more than 8 weeks, then it becomes much more likely that that cough is due to some underlying condition that should be diagnosed by a doctor and treated. And oftentimes treating that underlying condition will make the cough go away. And those 3 most common things are something we call postnasal drip in layman's terms. Number 2 would be asthma, and number 3 would be acid reflux. So that's chronic cough. Now, once a doctor has appropriately evaluated somebody and has treated those 3 things to see if it'll make the cough go away, and the cough does not go away, meaning it's been refractory to all of those treatments, then and only then can we give a diagnosis of refractory chronic cough, or RCC. And Tanya, you made a very good point. Once a cough is diagnosed appropriately as RCC, then what we in the medical field have been trying to teach our colleagues about is that at that point, the cough isn't just a symptom of something else, it's its own separate disease entity. And we think it's because that person has a very sensitive cough reflex, and they cough for reasons that don't make other people cough. For example, cold air, strong smells like perfumes and colognes, laughing, singing, talking, spicy foods. These kind of things either typically don't trigger cough or trigger a mild cough, but in those with RCC who have these hypersensitive cough nerves, they're extremely sensitive to these things, and we think that's the underlying reason for RCC.
Thank you so much for that explanation of what it is and the way that it presents oftentimes. And, you know, it might make you think that this is a rare disease or uncommon that people cough for greater than 8 weeks with in the context that you described. So how common is this, both maybe in the US and abroad?
Yeah, you know, when you talk about RCC, it sounds kind of exotic, right? But cough is such a common thing. In fact, every few years, the United States Department of Health and Human Services does a survey asking, why do people in the United States go to the doctor or seek medical attention? And the results of every one of these surveys for the last few decades has been always the same, and that is that cough is the #1 most common complaint for which people in the United States seek medical attention. Okay, it's not #3, it's not #7, it's #1.
Wow, that'll
Accounts,
surprise some of our listeners today for
yeah,
sure.
and it accounts for about 16 to 30 million visits a year in the US, depending on, you know, which database you look at. But of course, that's for all cough, right? So a lot of that is going to be acute cough, subacute cough, like we mentioned, and some will be chronic cough. A more difficult question that's always asked, but difficult to answer is, well, how about chronic cough specifically? How common is that? And obviously, there's no way to have a specific number because, unfortunately, until October of 2021, I believe, there wasn't a specific code for chronic cough for doctors to use. Like when we see a patient in the office, once the patient leaves and we're filling out our note, you put in a diagnosis code. So only up until 2 years ago, 2.5 years ago, was there even a code for chronic cough. So docs would put cough, and then it became just one big basket. But we have several research studies that have been done over the last few years, just trying to get a sense of how common chronic cough is. And those have usually been like survey studies where either in the United States or in the UK or in Europe, you know, people have been surveyed and asked, have you in the past year had a cough for 8 weeks or longer, that kind of thing. So, you know, it's fraught with issues in terms of, you know, the accuracy and all, but the numbers that have come out of multiple of those studies have shown that anywhere from 4 to 12% of people will say that they have suffered chronic cough in the prior year. So 4 or 5% of a large number is a large number of patients. So chronic cough definitely is not uncommon.
Now, do we see any regional differences throughout the world? Any nuances that we might be aware of?
So that's really interesting. Who is that, you know, typical chronic cough patient, right? So there isn't a typical chronic cough patient. They come in all ages, shapes, and sizes. But it is fascinating that, for example, I and my New York cough center and my colleagues around the world, there's a very typical demographic. 2/3 of patients who come to chronic cough centers for treatment are women, 2/3 women, because women actually have a more sensitive cough reflex. And we know that by measuring the sensitivity of the cough reflex in the lab by doing something called a capsaicin challenge, where we have someone breathe in capsaicin, which comes from red hot chili peppers, and they cough. So women have a more sensitive cough reflex. So in my cough center, and when we looked at the cough centers around the world, the most common type of patient that will seek attention is a woman in her 50s and 60s. That's the main, so age 50s and 60s for men and women, but women predominate over men. But obviously, it's a problem that can affect everyone. But that's the most common type of age group, and is the female sex predominance.
So you've already talked a little bit about what some of the potential causes may be and the way that recurrent chronic cough, RCC, is diagnosed, but expand there. Help us to understand how does this show up for a person who perhaps is having these symptoms and doesn't really know what's causing it or where to go to be diagnosed?
Right. So That's why, the eight weeks isn't, a perfect number. It's kind of arbitrary, but as I said, after 8 weeks, it becomes much more likely that your cough is due to some other condition that may be treatable, as opposed to the acute and subacute coughs that tend to go away on their own after a few weeks. So you should see a physician if a cough is more than 8 weeks old. And of course, the initial things the doctor will do is make sure there are no absolute, what we call red flags, things that mean there's something active going on that you need to immediately be treated for. And that's, if you have a fever or shortness of breath or coughing up blood or, something that may be a pneumonia or something, then obviously that's, off for emergent care. That's usually not the case, but obviously you want to rule those things out. But at that point, the doctor should evaluate the chronic cough, like I said, looking for those three common treatable things: postnasal drip, asthma and asthma-like stuff, and reflux. And I would say probably in the right hands, the majority of folks with chronic cough will be treated successfully if they go through a very thorough and complete evaluation that, can take months, because you treat each of these three things, as we say, empirically, meaning if somebody doesn't have obvious postnasal drip or obvious asthma or obvious reflux, the doctor will still treat those things, but each of those treatment periods takes a while. So it could take a few months to go through the whole algorithm, as we say, of treatment. And then, and only then, once that thorough workup has been done, can we then render the diagnosis of refractory chronic cough, or RCC. Right. So since I run a specialty cough center, I tend to see patients who typically, before they see me, may have seen 6 or 8 other doctors over the course of months or years, or even sometimes decades. So what you're getting to is a very common experience that we refer to as the chronic cough patient's journey. So for example, a patient will start with, perhaps their primary care physician. If the cough isn't successfully treated, then the primary care physician will refer out to a specialist. And in the United States, probably the most common specialist to whom a chronic cough patient will be referred is a pulmonologist, a lung specialist. But not far behind are the allergists, who see a lot of chronic cough patients. And then thirdly, the ENT, or the ear, nose, and throat doctors. And also the gastroenterologist will probably come in fourth if there's a concern that acid reflux might be the cause of the cough. And unfortunately, what we see is that patients go through a whole, cycle of seeing all of these specialists. And even though those doctors did their best, they were not able to treat the cough. And they're basically told sometimes that, look, we've done our best, but we can't fix your cough. And then the patient unfortunately goes off and maybe just tolerates the cough for a while. And then after some period of time, they'll maybe find a new primary care physician. And that physician, also trying to be helpful, might send the patient out to another series of consultants, another pulmonologist, another allergist, another ENT doctor, another GI. And unfortunately, what happens there is oftentimes, and we call it patient churn also, that they go from doctor to doctor, and the doctors are trying their best. And unfortunately, oftentimes tests get repeated unnecessarily. Like if the first chest X-ray was normal, they'll get a second X-ray. If the first breathing test was normal, you may get a second breathing test or a CAT scan or a second ENT exam that, after the first one was normal. So there's a lot of repetition of tests being done. Because the answer to what's causing the chronic cough remains elusive, and all of the physicians are doing their best to try to get to the bottom of it. And that's one of the most frustrating things that patients report to us, meaning those of us that run chronic cough centers, this this churn and this cycling from doctor to doctor without really getting a diagnosis. I think what's really revolutionary about our introduction of this concept of refractory chronic cough is once folks realize that refractory chronic cough isn't necessarily the fault of something else, it's its own specific condition. So I find the concept of RCC very useful because it helps me understand, why am I seeing this patient in the office with me who has a chronic cough? Now, the things we talked about, postnasal drip, asthma, acid reflux, these are very common conditions, right? Billions of people in the world have one or more of these conditions, right? Not millions with an M, but billions with a B. But only a small percentage of those folks with these very common conditions have a chronic cough. And then a further smaller subset of patients with chronic cough that's reversible fit into RCC, refractory chronic cough. So it's important for us as physicians to realize this is a specific disease caused by, as I mentioned, hypersensitive nerves that cause cough from triggers that don't cause cough in most people. So it's interesting, it's important for us doctors to realize what RCC is, but also maybe as important is the fact that when we speak to our patients about RCC, oftentimes we're the first ones to validate for that chronic cough patient is what you have is a real medical condition, okay? You're not a complainer. You're not just making it up. We understand that chronic cough can ruin someone's life. And the concept of RCC being a real disease validates that, just like the person with diabetes and heart disease and asthma, chronic cough is its own specific medical entity that needs to be treated as such. So I think that's probably in the last 10 years been the most important thing to come out of the chronic cough world, where we're trying to teach both our colleagues and the outside world about this concept of RCC being its own specific medical condition.
Yeah. So after that, after we do realize this is what a person has, what does that treatment or long-term management plan look like for those patients living with RCC?
So unfortunately, we do not have a specific medication approved for RCC. Up until 1 or 2 years ago, well, up until I guess last year, I would have said there's never been a medication approved for chronic cough, any type of chronic cough. That's still true in the United States, unfortunately, but there was a drug approved in 2022 and 2023 in Japan and Europe. So this drug is available, but the United States FDA chose not to approve that drug. There is a similar drug currently in clinical trials, and the hope is that those clinical trials will end in 2025. And if they're positive, the hope is that that drug will be approved in 2026. Not that it's going to be a cure-all for all chronic cough, but it'll give us something. So as of right now in the United States, physicians do not have a single approved drug to use for refractory chronic cough. So we work with what we have. So we tend to use medications that are called neuromodulators. Typically, it's amitriptyline or gabapentin. And these drugs, from the name neuromodulators, they're felt to sort of suppress or cool off these hypersensitive nerves that cause this chronic cough. And in some cases, these medications are effective, but unfortunately, in many cases, they're not effective, or they might be effective for cough, but unfortunately, especially in the case of gabapentin, they cause a lot of drowsiness. So, it's these are medicines that are work for and are tolerated really by a minority of patients. Now, I have had some success with these medicines, so they should be tried, but unfortunately, they are not great. Narcotics can suppress cough, but again, narcotics are not something that seems particularly desirable for what might be long-term treatment. But the other thing that we've learned over the last, I'd say, decade or so is that the speech-language pathologist can be a very, very useful addition to the chronic cough care team, because there are certain speech-language pathology exercises and techniques that can really be helpful for the refractory chronic cough patients. So I've been very impressed, and there's actually been research studies published showing that speech-language pathology can help even the most difficult cough. The problem is that at this point, there's still very few speech pathologists in the United States or worldwide that are expert in chronic cough, and we are desperately trying to get more speech language pathologists involved. But you can be at a major medical center, for example, and your doctors may not have access to a speech pathologist who's expert in cough, but that can be very useful. And I always consider that in my difficult RCC patients, because in some patients, not even drugs, but just the speech language therapy techniques can be very useful to, if not cure the cough, just take the edge off the cough. So I think that's an important point to be made.
Well, Dr. D, we could go on and on because there's so much to learn about this topic, and our time's a little bit limited here today. So I want to think about, on this first World Chronic Cough Day, what are the hopes and futures that you have for this space? I mean, you've already talked about some of the amazing work and the importance of, the innovation in this space, the potential for new treatments. But if you were to look into your crystal ball and all the research, all the patients that you have been working with and continue to work with today, what do you think this will look like in the next 5 to 10 years for those out there living with RCC or loving someone who does?
Well, thankfully, Tanya, we can finish our first World Chronic Cough Day on a positive note. I think I've been maybe a little bit negative, talking about how bad cough is and how difficult it is to diagnose and treat, and how right now we have no medications. But actually the last 10 years or 5 years, especially in chronic cough, have been very, very exciting, because in the last 10 years, we've learned a lot about the mechanism of cough, how these hypersensitive nerves, how they get hypersensitive, how they work. And when we understand the science more, that has led to actually a lot of drugs being developed that are now in clinical trials. So if we were talking 10 years ago, I would have said, sorry, there's nothing going on. But I can think off the top of my head, at least 8 drugs that are now in trials in phase 2 or phase 3 for chronic cough. So there's a lot of work being done. As I mentioned, the first ever drug has been approved in other countries. The drug that's similar to that is maybe going to be approved in 2026 in the US if all goes right. But that's one specific molecule, the so-called P2X3 antagonists. But beyond those, as I said, there's 6 or 7 other drugs in the pipeline in earlier in phase 2, right? Phase 3 is the big study before a drug gets approved. But there are multiple phase 2 studies looking at all different types of drugs to suppress the chronic cough of RCC. And it's been a very exciting time, really a boom time for cough research. So I can leave on a very positive note that it's gone from no activity to being a very active field with numerous drugs being looked at. And we're all hopeful that maybe in the next 2 to 5 years, we'll have not just one, but hopefully multiple medications available for our patients with RCC.
Well, that is absolutely our hope as well, as patient advocates in this space. As someone whose personal journey includes my grandmother who lived with chronic cough for 50 years, and there were no solutions. There were no doctors. Most of them thought it was all in her head, even though she coughed hundreds and hundreds of times a day and had a lot of other physical complications and mental health complications as a result of chronic cough. It was totally misunderstood and misdiagnosed and just missed all around. So I think getting to that day 5 to 10 years from now, or even in the next 2 to 3 years, where we diagnose and treat this condition as a disease, not just as a symptom, but fully recognize the impact that it can have on one's life. And where there's not just 1 or 2 centers of excellence like the one that you lead, Dr. D, but where the access to this care is much more broadly accepted and universally understood throughout the world. This is what our hope and aim is in actually initiating this first World Chronic Cough Day, and in all of the efforts that we are stepping forward into in communicating with the community, the patient community, building that community, and keeping them informed. So thank you so much for being here and for spending some time with us. We really appreciate the ongoing effort and leadership that you've exhibited in this space, and we will look forward to continued conversations.
Okay, well, thank you so much for having me, and congratulations on our first World Chronic Cough Day.
Thank you.
Hello, everyone. We are thrilled to be here on this first ever World Chronic Cough Day. I am so pleased to welcome a friend and colleague in this space, Mitch Silva. Thank you for being here, Mitch.
Thank you.
Such a pleasure. So we are the second presentation today. We get to close things out on this webinar today. We're following Tanya and Dr. D speaking about the treatment and management of refractory chronic cough. And so now we'll talk more, I think, about the patient experience and resources that we have available. But first things first, I want to do a proper introduction of Mitch, who is one of our most excellent and most active patient advocate. So we're very lucky to have him here today. So Mitch is CEO and one of the co-founders of an organization called Asperity we'll learn more about. It's an organization working toward a healthier future through patient empowerment programs that address many things. So challenges such as social isolation, improving patient-provider relations, education related to conditions and their treatment, and of course, more. So Mitch has a master's degree, a PhD in bioengineering. That's from the University of Leuven, Belgium. And he's also a founder and chair of EUPATI in EUPATI, Belgium, the European Patient Academy on Therapeutic Innovation. Very impressive and very difficult to say. Thank you for being here, Mitch. Always wonderful to see you.
No, thank you for inviting me, and it's always great collaborating with you. So it's like you said, you're a friend, we're colleagues with shared purpose. So this makes it very exciting.
Wonderful. We're so lucky. And this first ever chronic cough day, it's so fulfilling to think about that being on the map, right? Getting noticed for refractory chronic cough for all these people who for so long have been coping with this chronic illness. So thank you so much. So let's start with the basics. So your background in chronic cough and what's your experience with cough in general?
Okay, indeed. So let me start with my experience. So I've been working actually on quite a big project to actually understand what is the burden of patients living with chronic cough. So the idea was to really get a bit more insights and what the impact is of cough on everyone's life. So we actually interviewed a lot of patients that are actually coughing for already years. Some patients even up to 10 years. So really very long time. Besides that, I actually also have a little bit of research experience in cough because my PhD was partly so analyzing cough sounds. So there's always has been a little bit of a affinity there with the cough world. Besides that, I actually also had a personal story. So also about 8 months, I was actually a chronic cough patient myself. Luckily, that got resolved.
Thank goodness, because we'll learn a lot about the burden of that as we talk to you, both at the personal experience and, of course, with these many patients with whom you've worked, who we thank for their participation in all this work. But it sounds like you have been able to experience cough from many angles then. So this will be very informative for us today. So let's start with, we'll be speaking mostly, I think, in this conversation to the patient experience, right? What prompts patients to see a doctor? Who do they go to? Do they go to their GP? Do they go to primary care? What does that road to diagnosis look like for people? What can you tell us about that?
That's a very important question because my experience talking to cough patients is really that, of course, depending on the ecosystem you're in, sometimes you have a health ecosystem where you directly can go to the GP. Sometimes other countries you can go directly to the specialist. So what we often hear is that when you experience cough in the beginning, you actually just think, okay, it's just a cough. You keep on coughing, then you start becoming worried, and then some people might go directly to the GP. Others will just, keep on working, keep on caring for their families until the environment actually asks questions like, okay, but are you okay? Because that doesn't seem right that you're always coughing. So depending on personal situations, people might go sooner or later to a medical specialist. And so mainly the people will go to the GP, and there you directly end up into a medical pathway, of course, where at first sight, okay, they might think maybe it's just related to a cold, or maybe it's asthma, so maybe you should go and see a pneumologist, or maybe it can be something related to nasal polyps or reflux. So go and see a ENT, for example. So depending on this referral path, this can take sometimes, up to several years. If you're very lucky, this can be short. And this is really a very, very big challenge that we see and that we hear again and again with every chronic cough patient, that first of all, the moment that you start coughing, it's something that, gets into your life very silently, and suddenly you feel that it's taking over. It has impact on your daily life, your sleep, your family life, your work. You can't go to the groceries anymore, the grocery shopping anymore, because when you open the fridge, you start coughing, or when there's a strong perfume somewhere, you start coughing. So the triggers can be also very, very different from person to person. And this makes it actually very difficult as well to really understand, okay, what are these patterns in this cough? And and this, of course, also relates back when you are going on a consultation and you have to explain, okay, what is your situation? What is your experience? If you're lucky, in a sense, they will diagnose you with a certain disease, and when you get a treatment, it will solve the cough. So personally, this was my case as well. So I had about 8 months a cough that was really impacting also my work, my sleep, and everything. But then by changing medication, I actually got rid of the cough. So I was actually lucky, but it took 8 months. So imagine that you are living 10 months, 10 years even with a cough, what impact this can have. And this is, I think, a mission that we have to advocate for as chronic cough advocates. How can we reduce the time to diagnosis and the time to treatment? Because when you talk about chronic cough, there can be a cause, a medical cause, but there's also something that we call idiopathic chronic cough, or unexplained refractory chronic cough. And this means actually that you have gone through several tests, examinations, and you still have this persistent cough. So you can't actually find the cause of your cough. And this is a situation where it becomes frustrating, both for you as a patient, but also even for your physicians, because we spoke to so many physicians, and they also mentioned that it's really very frustrating for them to not be able to help their patients. And this is why, by actually working together, by really help patients ask the right questions, to go to the right physician, to get referred sooner as well. And also with that, educate physicians to say, okay, where should we look at in order to really help patients that have this persistent cough to reach the right diagnosis. So it's really a very challenging journey for patients.
One of the more challenging journeys that I have heard of getting to diagnosis. The thought that it shows you, I guess, how severe the impact is of the symptoms, that someone would persist in 10 years for finding a diagnosis, rather than saying, you know what, they're not going to figure this out. I'm going to just do what I can to cope with it in everyday life. But what you're telling me, I think, essentially, is that that's not possible. They're not able to live their lives. I think that's the part that's hard for people who maybe don't know too much about chronic cough. What does it really look like in the day to day? And I'm sure it's different. There's, as Dr. D said, there's no one chronic cough patient, but what was it like for you? What about the patients that you engage with?
Yeah,
What does the everyday look like?
Indeed, this is something that I was personally very shocked hearing these stories. So there were so many patients with chronic cough who actually had to quit their jobs, or they got fired because of their cough. And so can you imagine that you are a nurse, you suddenly get this cough, people ask questions, they think you are infecting them. So as a nurse, you cannot function. Then, okay, you stay home, you can't find a solution, you go back to work. So it's a spiral. And this is only one example. We hear so many other examples from patients that actually just had to stop. Recently, I saw a lawyer, so a very successful lawyer, but she was always coughing, and this made it very embarrassing for her and annoying for her, and also for the clients. And then she also had to stop her job. So these are just some examples how impactful a chronic cough can be. Also families. So some weird couples that actually really had issues, relationship issues due to this cough, because there was a sense of not being able to rest, that there's always this cough there that is persisting, and some people get a bit annoyed and irritated, and this leads then to more aggravated situations. So it really is not to be underestimated, and often it can really start with the morning. You stand up and then suddenly, boom, you start coughing. And some patients, they really have it like in bouts. So they have a burst, a cough burst, and it can last a few minutes. And some even also have to or have the sensation they have to vomit as well. So it's really it goes quite hard. And some people, they really have to grasp air. They need to relax because it's really so impactful. Also physically, there's even stories that people broke their ribs from coughing. And then sometimes it can be that you're okay for a few hours, and then suddenly, boom, it hits again. Other patients have it more frequently throughout the day. So it's really not really easy to find the patterns. And this is also a question that we often heard from, or a frustration that we heard from patients, that it's so unpredictable. It's so unpredictable to see when does it come and how hard will it be. And the moment that you feel it coming up, you already get anxious because it's really so impactful. So you really have to sit down to just recover after you have such a cough burst. And also imagine going to restaurants. We heard a lot of people that said we just cannot go to restaurants anymore because it's just annoying. The same for going to the theater or the supermarket. So it's it's impacting every single aspect of your life. And this is something where in this Chronic Cough Awareness Day, we really have to bring this to attention, that a cough is not just a cough, especially if you're dealing with it for so many years.
And I think that going back to the physical impact of it, and you mentioned, anxiety, I can imagine that the mental health burden of this is quite high. I can imagine that people feel isolation strongly, that they become depressed often, that anxiety is quite high given the unpredictability. Is that what your patients have experienced?
Absolutely. I think what you mentioned is absolutely confirmed. Also in research, so there has been research done as well, measuring what is the impact also on the mental aspect of living with a chronic disease. And when you look to, for example, indeed depression, anxiety in the chronic cough population, this is really higher compared to other groups. Especially it's not an invisible disease. So not to say that invisible diseases do not lead to depression, but it's really something you cannot keep for yourself, basically, because it's so, you cannot always control your cough, because suddenly you try, but then it comes out and you just feel bad. And imagine this happens again and again, and you lose self-esteem in a sense. And this is where patients really need support as well, to see how do you cope with such situations, to not take it too personal, although it's a personal thing, but to see, okay, how can you cope with it also in a social environment beyond pure the medical physiological coping with a chronic cough.
The impact is immense as you're describing it. I was really trying to sit here and think of an environment where you would feel safe, or that it would not impact your functioning. And the only place I can think from is if you were working from home, and even then it would, because of the burden of the repetition of the cough and being on Zoom meetings and that type of thing. It feels like there's no environment where you would feel completely protected, right? Or that you would be in a situation where it would not interfere. And that over the course of many years must be incredibly taxing for people. So I think it's a good thing for us to remember on this day, right? To make us even more passionate about getting eyes and ears to attend to this condition that's not often talked about. So let's talk about the patient experience of treatment. It sounds like it takes a very long time for people to get diagnosed, and even in the best circumstances, in your circumstances, it was several months before it was gone, which I imagine was very difficult too, but in many cases, years and years. So when they get to a point where they have been diagnosed, what are patients saying about their treatment experience? Are there all the options that we need in order to support people with chronic cough?
This is a very vital question as well, because actually what we see is that there's two types of or classes of cough. So the ones that patients with a cough where you find a medical cause, a medical reason. So this can be, for example, asthma. So imagine that you have asthma or you don't have asthma, suddenly you start coughing, and it might be that asthma is the underlying cause of this cough. So if you treat your asthma, it can be that your cough will go away. So in that case, okay, you will get rid of your cough, but of course you have to maintain your treatment. So it's important to really take disease management serious as well and make sure you adhere to your treatment. And the same for reflux or a postnasal drip. So if you have nasal polyps, for example, this could also cause cough. And if you take a treatment, it can be that the cough will go away. This is one class of patients, I would say. The other class are the ones that actually they went through primary care, they went through the specialists, and then they got misdiagnosed with asthma or misdiagnosed with reflux or whatever it is. And then you see that these patients, they get actually sent from one specialist to the other, and they can't find a solution. And we also feel that these patients lose hope in the system, and they say, okay, anyway, I will go, but they won't be able to help me. So you really feel that in the beginning, you feel that there's a sense of an empowerment, that they want to look for a solution, and you really want to just get rid of that cough. But the more you are in this trajectory and the longer it takes, you really feel that the empowerment level is going down, meaning you lose hope in the system, you lose hope in yourself sometimes as well. And this is again where I think we have to see how can we develop solutions, tool ecosystems to make sure we can support these people to actually find this this empowerment again, to ask the right questions, to not give up, because it's really about being persistent in that case in order to find a solution. So in terms of treatments as well, there are like, of course, the traditional cough syrups, etc. Some might work, some not, depending on your situation. There's also other types of medication. Some might actually contain certain opioids. So these have, of course, their certain side effects as well. And then there's luckily today new classes of treatments that are arising. And this is actually the first time, I think, in years that chronic cough patients can have hope. So of course we always have to be careful because everyone is unique, but it's really, I think, a game changer now that innovation is finally coming into the space, and hopefully we can change the quality of life of those patients suffering with chronic cough.
Love to be able to do that and look back in 5 years and say, look how far things have come. Like Dr. D said, he said a decade ago, I would have said there's nothing coming for us. There's nothing coming for our community. And he said, luckily, we're at a different point right now. So the thought of 5 years from now is pretty exciting to think about. And
Absolutely.
I think, wouldn't that be nice for people seeing this? That's one of the things you can feel the hope coming from Mitch and certainly from Dr. D too. I hope that people seeing this, A, of course you are not alone, but B, you can be helped, right? Keep the faith on this and use some of the resources we can help to better equip you to have those conversations and to find the right person that you need to do. Because hope really takes you a long way, I think, whenever you're feeling isolated and that down.
Absolutely. I think hope is really the driving force. And maybe that's why I can maybe explain a bit of some resources that GAP
I
put
love that.
together. So when you go to gap.org, you can actually click through to the chronic cough web pages, and there's a whole bunch of resources there. So these resources are actually quite interesting, I think, because we actually co-created them with patients. We also got them validated by medical professionals. And it really gives you a kind of a guidance, a kind of a navigator actually to see, okay, where am I in my journey? What questions should I ask? Who should I see? So by actually going over this content, it can actually trigger certain questions. And this is where we really hope to empower people and actually to ignite this flame of hope again. And besides that, there's also the Chronic Cough Ambassador Program. And this is really something that we designed to help people that want to become an advocate in chronic cough to really get the basics right, to really understand a bit more what is a cough exactly, what is the difference between an idiopathic unexplained chronic cough and a chronic cough with a known medical cause. what are the current treatment options out there as well? What are the resources out there where you can actually go to find support? So by actually offering these programs, we really hope we can actually strengthen the community to really advance science as well, and make sure we can actually bring science and the support that is needed to actually also have impact of the science to patients living with chronic cough.
I'm so glad you said that, because I think too, it can be very difficult when you are a person or a person with a chronic condition, or someone who cares about them, who loves them, a family member, pardon me, to know where to find those resources, that these exist, but you don't know where to find them. And I think being able to find them through GAP, the chronic cough page, and all the work you have done, it's really exceptional. The resources that you have compiled through Pause Your Cough, excuse me, will be very helpful to people, I think, in knowing too that this is something that we are attending to. That this is not an obscure condition that does not have a spotlight on it. And that's part of what we want to communicate here today, that we wanted everyone to join us in that conversation, I think. Let me ask you a few more questions if you have a few minutes. So one of the things, I know you're well versed in the many issues that lead to high patient burden. So tell me a little bit about what you think can be done to tackle some of the issues that surround that.
That's actually a complex question, because the patient burden, I think when you look to the different dimension of burden, there's actually a lot to be said. So it can be a burden of actually just, finding the right physician. Now, this can be seen as a burden because you have to actually swim through this whole ecosystem. Sometimes it's easy, sometimes not. Sometimes you have insurance, sometimes not. So there's so many factors that can actually cause delay to get to the right specialist. And so this can be one dimension of burden. Another dimension of burden is also like pure social and your social environment. So that's a burden that can start also impacting how you feel, like we talked before, depression, etc. So what can we do there is really create awareness, I think, with patients. What can you do to actually find a solution, but also make sure that your environment also understands what it is. Think about also employers. What can they do with employees that have chronic cough to make sure that it's something that people can talk about on the work floor. So we really fight the stigma, because sometimes people might think, okay, he's coughing or she's coughing because they might think they're smokers, or they might think they have a certain infectious disease. So imagine during COVID, for example, how these people, what these people had to live through. So this is a really very high burden. So there's also pure financial burden as well. So imagine that you lose your job due to your coughing. This can create so much stress also on that level. So I think burden really has different dimensions, and I think it all starts with making sure, of course, we can bring awareness, making sure that we can also support science as a community to develop solutions, new therapeutic innovations to actually help patients with chronic cough, and also provide the right tools to patients. So there's a nice tool actually called Hive, I think it is, where you can actually download it on your app to record your sounds, your cough sounds. So you can actually see what are these patterns, and this can also help actually to facilitate the discussion you have with your physician. Another activity or action you can take, I think, to reduce the burden is actually keep track of your personal patient journey. So sometimes you forget actually over the years, when did it start? Who did you visit? What tests did you do? And by bringing this all together, that can give clarity to you, but also when you are discussing this with your physician. So this will really take away the burden of actually the patient-physician communication, which sometimes is not as easy as it seems. So I think there's a lot to be said about burden, and I really hope that thanks to this Chronic Cough Awareness Day, we can really start developing a program that we can put in place and that we can also share across the globe to tackle these burdens.
That's good suggestion. I have a different chronic condition. I have chronic hives, and I will tell you that over the different decades of my life, my memory of them is very different than what I have written down. It is very interesting, right? And it's just a matter of time passing, right? I think the other thing is that we're not great reporters of frequency of things and exactly what are their triggers that are associated with them because we're looking at everything in hindsight, right? So that documentation can be so important. And the other thing I think it does, and it has for me, it's very empowering. It's very empowering. It's almost documented proof that this exists and this is something sizable as I experience it, right? And I think it's also very helpful, as you said, to improve communication because people like data, our physicians like data. So having that and being able to show that to them can be very helpful, I think. I love all of your ideas. Not surprising. I love all of your ideas. So thank you so much for that. Now, before we close, I have to ask you a question that I love to ask people. And I know you'll have many good ideas, but if you had a magic wand for chronic cough, what do you want to see happen for patients and their families in the near future?
I think the ultimate solution would be to just have something, whatever it is, a treatment, a solution that can actually help you to get rid of your cough. I think that's everyone is looking for, and we know that there are innovative solutions out there. So I think it's also to be aware about clinical trials, for example, that are there because they can help you. And even if these solutions might not help completely, hopefully it will also help you to just understand a bit more your condition to keep on searching as well. So I really am convinced that having hope on a treatment that can directly eliminate cough, of course, would be the best. But if this is not the case, I think it's important to do not lose hope. So the magic one there would be actually a framework where you can go to where you really know if I feel anxious about something, when I have questions, I know when I will go to, for example, the gap.org website, there's a lot of resources, and it will give you kind of a navigator to really take you to the next step.
I love that. I love that. And I love leaving on a message of hope. And I think the more that people can share their stories when they're comfortable doing so and their experiences and speaking up about chronic cough, the more it will become something that is, accepted as this is actually happening in our communities. This is not rare. This is not a rare condition, right? And so maybe through conversations like this, through the first ever World Chronic Cough Day, but also patients speaking up and feeling empowered to do so, that it's okay. You don't have to hide because you're worried about your cough or you feel ashamed of it, that this is something we're all working to get to the bottom of so that we don't have to have this conversation again in 5 years.
Absolutely. It's all about having a shared vision, fighting the stigma. And also, if you really are experiencing chronic cough, sometimes I heard from patients as well, just mention it up front. I have a chronic cough, so don't be worried. I am not infectious, and let's move on.
Yes.
So there's little things that can help. And by just, getting inspired by other people, I think it can really help in your daily life. And hopefully at the end, we will have a cough-free world, let's say, of course,
Yes.
for these refractory chronic cough patients.
I look forward to talking to you when that happens. We will have another conversation so we can celebrate for all of our colleagues and patient peers. So thank you so very much for being here on this big day for all of us in this community. Thank you for giving patients hope and for all the resources that you have worked to create to ensure that people can have a better, more empowered life with their cough. I thank you for joining us. Always good to see you.
Thank you very much, Kirsten. It was great to talk to you, like always, and I really wish you a lot of luck with this beautiful initiative.
Thanks so much.
Thank you.